Welcome back to another episode of PT Meal Physical Therapy Podcast, your weekly serving of insights, information, and inspiration from the experience and expertise of Filipino physical therapists. I am Johan De La Paz, your host. Let's go on with the show. So for today's episode, we are going to talk about working as an oncologic physical therapist. So my guest today is a physical therapist specializing in lymphedema and oncology rehabilitation, Mary June Nocete. Welcome to the show, June.
Thank you. Hi.
Hi. So, before we dive into the topic, could you give us a little background on how you started as a physical therapist to what led you to your current roles now?
Yes. Well, I'm a licensed physical therapist in California. I live in Los Angeles. I moved here in 2009, I think. And I started as a physical therapy aide for a skilled nursing facility while I was studying for the board exam. I passed the board in 2010, and in California, before you can treat as a physical therapist, you have to have like an internship for 10 months. So I did that in acute setting. I was rotating with a couple of hospitals. And then I got my license. And then from acute settings, I had experience in skilled nursing facility, home health, boarding care, adult daycare centers, kind of overlapping. But in the past 6 years, I've mostly been in outpatient physical therapy. That is where I decided to get my certification in lymphedema training. I got certified maybe almost 4 years ago now. Prior to that, the reason why that led me to lymphedema was I was doing wound care in the acute setting, and I saw the need for physical therapists who are specialized in lymphedema. Most often with wound care, it's nursing. However, I really, really appreciate the roles of physical therapists in the wound care and edema, chronic edema, because we're in charge of mobility, modifications, and adaptive equipment that some nurses won't be necessarily exposed to. So then, lymphedema certification is quite expensive.
Right.
Very expensive, actually. But luckily, in this outpatient setting and company that I am currently working for, they have a very generous package for CEUs, and that's how I got my certification. So then I started treating lymphedema patients in the outpatient setting. Initially, I thought I would mostly be seeing cancer patients or patients diagnosed with cancer, but I found that it's actually 50-50. 50% was related to cancer related, and 50% was vascular. So the vascular would be bilateral lower extremity edema, which actually is a little bit more complex in the treatment setting. So then that led me to getting my certification as a cancer rehabilitation specialist. I would say within the year. So then I'm slowly building that program into that outpatient clinic I'm working for.
When you started here, because you've been around, you've been in a lot, all the settings, even settings that I haven't heard of, like board and care. Do they have physical therapists there? I thought they were just they just stay there and be taken care of by nurses. So you've been around all the settings, and did you have an idea that you're gonna go to you want to specialize on lymphedema and cancer related conditions?
Actually, no. I didn't really plan it. I knew that I was always interested in the wound care and the lymphedema, but I never really, I didn't have that need, I guess, or want to really specialize in anything. When I first came here, I was just working a lot. That was the whole point, was just to work, get experience, but also, of course, financially, it was very important for me. But it kind of, the opportunity just kind of unfolded itself. When I went into the outpatient setting, one of the physician doctors there were asking if we knew anybody who does lymphedema treatments, and I said I'm very interested. I've been always interested about it because, you know, in school we never really talked about that system, and I don't think any school, even here in the United States, are really, you know, putting that in the curriculum, because I've talked to some of the lymphedema therapists across the country, and they said that it's not very common.
We just like brushed up with the topic. I remember with massage before, like
Right.
if patient had a lumpectomy,
Right.
then the arm would be presenting with some
Congested.
and edema. So that is the only time I remember, if my memory serves me right, where lymphedema or edema is being discussed. But other
Right.
than that, no.
No. And I think until now, and I think it's the biggest obstacle is because the school is expensive.
Mm-hmm.
It's very, you know, it's unfortunate that way, because I really feel like a lot more people would provide that treatment if it's a little bit more accessible, the information's a little bit more accessible. But yeah, the opportunity really just unfolded itself for me. I'm really, it's not an easy specialization.
Yeah.
It's not so much with the treatment itself, but of course, because you're dealing with patients who have chronic, and you know, some of them are in palliative care, you know, end of life care. So it can be emotionally fatiguing for the therapist, but it's also very rewarding, I feel.
Right, right. I remember the first time I encountered a patient with lymphedema. It was my lateral lower extremity. Like, really, her legs are really big. I was like,
Mm-hmm.
and the patient and the PT that I was following was trained to like do the wrapping, and I was like, am I expected to do the same? So I started researching on getting a certification, and you're right, it's really expensive. Like, I would love to learn more about it, but it's expensive, and the company was not gonna pay me to do that. So, okay,
It's
no,
very expensive.
yeah, but it was really interesting.
Yeah, I one of my goals actually in the future, it may be the far future, is to bring that information back home.
Mm-hmm.
Um, you know, whatever I'm doing right now in terms of program development in the clinic, I'm
Mm-hmm.
in the back of my mind, you know, I'm trying to see how we can translate this and bring it back to the Philippines, e- and really start in the school setting.
Mm-hmm.
And
Right.
you know, because I really feel like the teachers are going to be a good advocate for
Mm-hmm.
future physical therapists to be more knowledgeable about it, because especially with cancer, you know, there's a lot of surgeries and treatments now with chemo, radiation, that they really prolonging more lives now.
Mm-hmm.
So the good thing about that is, you know, more lives are being saved. However, there's a lot of side effects from the treatments,
Right.
and there's not a lot of people who know how to help these patients,
Mm-hmm.
you know, cope with the long, because most of them will have long-term side effects.
Mm-hmm. Right. So before we move on further, for those who are listening who are not familiar or have encountered with a patient with lymphedema, could you discuss with us briefly what is lymphedema?
So lymphedema is pretty much chronic swelling.
Mm-hmm.
That's what it is.
Mm-hmm.
Edema is palpable swelling. Lymph is fluid.
Mm-hmm.
It's the fluid that is circulated in the lymphatic system.
Mm-hmm.
It is responsible for the recirculation of waste products, protein, um, white blood cells, and water, so that it goes back into the venous system and it filters out through our kidneys and our urinary.
Right. And the common conditions that wherein you encounter these types of edema, or what type of condition?
So there's a primary cause, which is congenital. So it's
Mm-hmm.
hereditary, that you're born with malfunction, or I guess partial obstruction of your lymphatic system. And then there's secondary causes, which can be caused by a couple of things. So the most common cause around the world is it's by an insect, so called I don't know if I'm pronouncing that right. I still can't pronounce it right.
I think I know that word.
Filariasis. I think that's how we pronounce it. It's not very common here in the west side of the globe. Here, what's more common is vascular causes, where there's chronic venous insufficiency, so that it just builds up over time, where the venous system and the lymphatic system, fails, and swelling just stays in the limbs. And then you also have cancer-related lymphedema, which is caused by, initially was thought to be only caused by radiation and resection of the lymph nodes, but new research is saying that even chemotherapy can cause it now.
Gotcha. All right. And then we'll segue there now to oncologic physical therapy. So with people would just like have an idea, like oncologic physical therapy is dealing with patients who are experienced, like have cancers or have like cancer related issues. So what is different with oncologic physical therapy as to other aspects of physical therapy?
Okay, so with when you specialize in cancer rehabilitation, you will get patients. Sometimes the spectrum is large. It's large. You can get a patient recently diagnosed with cancer who's awaiting treatments because they may be experiencing cancer-related fatigue. So if they're experiencing cancer-related fatigue, then there's a lot of education that happens in the treatments, energy conservation techniques, pacing. If they need adaptive equipment, then you prescribe it to them. If they come to you after surgery, then that's also a different kind of plan of care, where you have to work closely with a surgeon to figure out what protocols you should observe with certain, like for example, with breast cancer surgeries, depending on the resection or the procedure that they perform, sometimes they won't be able to perform full trunk extension for a couple of weeks, or they can't go past 90 degrees for a couple of weeks. So you have to work closely with physicians if you want to focus on immediate post-op cancer surgeries. There's also the aspect of preparing the patients for radiation, like specific for breast cancer patient. They should be able to perform to achieve this motion in order to receive radiation. And after surgery, they won't have that mobility. So then you have to be working very, very closely with the patient to increase that range so that they can get the treatment of radiation. If they can't get their arms up in that position, then they won't be able to receive treatment, which can be detrimental to their health. So a lot of occupational therapists that are lymphedema therapists are working on that. So if it's not immediate post-op, you also have chronic issues. So then you'll have chemotherapy-induced neuropathy problems in their hands and their feet. Cancer-related fatigue is always a given. Cancer-related fatigue does not go away with rest. So you really have to work with the patient in order to slowly increase their tolerance to activity. Other chronic conditions is edema. So educating them from the beginning, the risks, how to monitor their skin, how to avoid triggers. Just explaining to them what lymphedema is very helpful to these patients. And then, of course, you'll have patients that are on a palliative, adaptive plan of care, where you're really just supporting them, making them comfortable, trying to lessen their pain as much as you can at the end of their life.
Wow. So it's not just patients who were did like surgery or yeah. So it's the spectrum is right. So because the first time I encountered a patient with cancer as referred to physical therapy, I was like, what's different with uh, treating this type of patient. When I assessed the patient, I looked at him as a deconditioned patient with decreased activity tolerance, easily fatigued, and I was like, okay, it's doable like that. So, but it's not always like that. So, what are the special considerations that you try to like see when you treat patients with cancer?
Well, it really depends on what stage of treatment they're in.
Mm-hmm.
So it if they are in current active treatment, then you really have to um, be in close contact with a physician to make sure that your goals
Mm-hmm.
is in line with the oncologist's goals,
Mm-hmm.
because it is important to be functional, but sometimes if there is joint mobility that needs to be increased, like the neck or the shoulder, then you have to make an effort to focus on those things. If they're preparing them for surgery, then you need to make sure that you're keeping the swelling down.
Mm-hmm.
But if you're seeing a cancer patient that's having long-term side effects,
Mm-hmm.
I would say that the physical therapy there is a little bit more similar than the usual.
Mm-hmm.
So you keep it functional based. You
Mm-hmm.
always want to just keep it functional based and patient goal oriented.
Mm-hmm.
Some of these patients, going through cancer and cancer treatment, they're amazing.
Mm-hmm.
They're just really, they're warriors. So it's really important to figure out what they want
Mm-hmm.
for the rest of their lives, and sometimes you have to ask the questions in
Mm-hmm.
order for them to figure it out themselves,
Mm-hmm.
because they won't specifically say it outright. So you're kind of like interviewing them. It's
Mm-hmm.
like motivational interviewing them and encouraging them to really plan for their future while they're dealing with the long-term side effects. So I guess it's functional based, but not just on a single function. You're thinking more like, okay, 3 months, 6 months, a year
Mm-hmm.
from now, what do you feel like you want to be doing, as opposed to our normal, orthopedic conditions.
Right.
Your goals are a little bit, closer to the present.
Mm-hmm. So you've talked about motivation in having cancer is a lot to deal with. So how do you motivate your patients that you're seeing in performing those activities and performing physical therapy? Probably with some of them in the back of their mind, they're unsure of the future. So how do you deal with that?
You listen.
Mm-hmm.
That's number one with cancer rehabilitation, is you listen, because most often when they see an oncologist, they're done in 15-30 minutes. That's, they're done with their visit.
Mm-hmm.
And there are resources out there, online. There's resources, in brochures, but I still think it's lacking the area where these patients can just talk about their cancer and
Mm-hmm.
what they feel about it.
Right.
And that's where we come in, because when I ask them, oftentimes when I see a first patient, my first question would be, well, after are you having pain and all those things? And we talk a little bit about their history of their cancer. But my favorite question would be, how do you spend your day?
Mm-hmm. Okay.
Because like what time in the morning do you start your day? Do you eat breakfast first? Because if they can give you that information, then you can really figure out which activities they're gonna they'll be having the most difficult time.
Mm-hmm.
Because when you ask them what's difficult for you, they'll say everything.
Mm-hmm.
Everything is difficult.
Right.
Going to the bathroom. With gynecological cancers, you'll have problem in pelvic floor.
Mm-hmm.
So it's important that you have a little bit of background of that as well.
Mm-hmm.
But really knowing what their day is like is important. You're kind of like, you're investigating without seeming, I guess, too
Nosy.
nosy. Exactly. Thank you. That's exactly what I'm looking
Mm-hmm.
for. And then they can kind of look back in their day, throughout, and look back at their day and think, oh yeah, you're right, I am having trouble there.
Mm-hmm.
So it's really awareness and having that respect for each other, because
Mm-hmm.
you have to gain their trust. Otherwise, if you say you're tired but we need to exercise, they're not going to do it.
Mm-hmm.
They won't
Right.
come back to you. I'm tired, I don't want to deal with it. But
Mm-hmm.
you have to gain their trust and say, I understand you're tired, but if you just rest, it's not going to go away.
Mm-hmm.
So I really think conversational interviewing is very important in cancer rehabilitation. And sometimes I spend a whole hour just interviewing them and giving them little bits of tips,
Mm-hmm.
energy conservation techniques, when to perform their diaphragmatic breathing, when to get up from the bed, when to lie down,
Mm-hmm.
you
Okay.
know. Yeah,
You
all
did
those
that
things.
things. Mm-hmm. Yeah,
Mhm.
I remember when the first patient that I was handled that is cancer related, when he said like I'm tired, and I was like, okay, let's sit down first, because I haven't
Right.
encountered anyone with it. I was like, why do I have to see a patient who's just doing chemotherapy? I don't see the need, because I was doing like home health. Then when I got there, then the need came out. It was really, everything was taxing for him. So taxing, like going out the driveways were even taxing for him. It was really tiring. So I had patients in skilled nursing, in the skilled nursing facility when I worked there, that are actively doing, I think, chemotherapy, the one that they have like the small box they attach to their body, and they take it out like after 2 days. So for those like types of patient, how do you encourage them to still move after, like, on days that they're really tired, or do you like let them wait and rest, then do the therapy after for that days? So how do
So
you balance that?
you never give them anything strenuous, of course. So we're
Hmm.
not talking about strengthening, like
Hmm.
resistance training. So
Right.
that's
Okay.
completely if you are going to teach that, that's later on, once you've
Hmm.
established a whole program already. But with those patients that you encountered, the first thing would be, I would say, diaphragmatic breathing.
Mm.
The diaphragmatic breathing, what I learned before is very basic, but now, through reading articles and learning through the other my instructors,
Mhm.
there you can be very creative in
Okay.
diaphragmatic breathing, and that's both a relaxation technique, an edema management technique, and also it helps with core.
Hmm.
So you
Okay.
have a core strengthening factor there. So really, if you can get the patient to perform very good diaphragmatic breathing, you're pretty much, you know, tackling all those goals.
Hmm.
Then you can also add some resistance, and that's what I learned the past year, is how to resist it in different ways.
Okay.
How to be creative about using diaphragmatic breathing as a tool to relax the patient and be in control of the activity.
Hmm.
So let's say if they're having trouble getting out of the bed, how are you going to incorporate diaphragmatic breathing so that they can take control of that activity? Same thing with brushing their teeth, combing their hair, sitting still,
Hmm.
waiting in line, all those things. Because I think that is a simple exercise that you can actually expand on.
Hmm.
And it will make sense to them.
Hmm.
It will make sense why they have to exercise. If you give them a bunch of exercises with a handout, that wouldn't make sense to them. But if you tell them, okay, in order for you to hang your clothes up, you have to do, this kind of shoulder flexion 5 times before you do that.
Hmm.
You're
Okay.
warming up for that activity. So it's really kind of, you're not really teaching them anything complicated.
Okay.
The simple, the better.
Hmm.
The more functional based, the better. So it's really up to the therapist how you're going to be creative about that. And that's the one thing I really like about it, because in the medical field you can't be too creative,
Hmm.
obviously. But this area of physical therapy, I feel like you can really kind of dig deep
Mm-hmm.
in your brain
Right.
and figure out how am I going to help this patient.
I like what you said, because commonly the way I thought about it is like, okay, patient is deconditioned, so I need to do a lot more like endurance training, like more reps, less weights. So that's my thinking back then. So I
Right.
guess now hearing that, um, that's a good point of view in handling patients with cancer. So you've mentioned deep breathing um, exercises, and I'm quite curious. How do you do a proper deep breathing exercise? How do you cue the patient in doing so, where it becomes your basis for your other functional training for them?
So I use a lot of imagery, I guess, if
Uh huh.
that you would call it. I would have them find the most comfortable position first, because you
Okay.
want to lessen the guarding.
Mm-hmm.
Okay, because if you have a lot of guarding, then that's kind of, you're not going to set yourself up for success.
All right.
So find the most comfortable position for the patient, and sometimes that's lying supine, sometimes it's side lying, sometimes hook lying. Sometimes you have to recline the mat
Mm-hmm.
sitting with a pillow in front. Sometimes standing is easier
Okay.
for the patient. So, I feel like that's the most important thing, is find the most comfortable position for the patient. The second would be explaining to the patient why you're teaching it.
Mm-hmm.
They have to understand why. We always say, you should breathe, but
Mm-hmm.
really why? Okay,
Mm-hmm.
but you want to keep the explanation simple enough for them to understand. You don't want to give a full scientific explanation. You just say, this is going to help you increase your stability in your body.
Mm-hmm.
It's going to help you compartmentalize your thoughts and kind of take control of your activity.
Mm-hmm.
Okay, so if you just give them some encouragement, like encouraging words like that, I never had a patient who said that doesn't make sense.
Uh huh.
Never in the past,
Yeah.
5-6 years. So after that, after you've explained to them and they're agreeable, because if they're agreeable, it's so easy to cue them.
Mm-hmm.
Really,
Okay.
sometimes it just takes one or two adjustments and they got it. So if we're talking about the actual cueing for diaphragmatic breathing, I would have them close their eyes and imagine that there is a balloon, like a children's party balloon
Mm-hmm.
in their belly. Okay, and then I tell them to breathe in through their nose and imagine that they're filling that balloon up with air. Okay, now I don't give them too many cues in the first few tries. Even if they're doing this, I kind
Mm-hmm.
of just let the thoughts sit.
Mm-hmm.
Okay, because if you give too much cueing, it feels like too early of a correction and the patient will start stressing.
Uh-huh.
Okay?
And they might get frustrated as
They
well. They
might
might.
get frustrated, right? So
Mhm.
you want to be calm as much as you can. And, teaching 3 to 5 reps of diaphragmatic breathing can take me 15-20 minutes.
Oh, okay.
It can. You
Mm-hmm.
just have, of course, in your documentation, you have to justify what you said, how the patient reacted, so that, in terms of billing purposes, then you're covered.
Mm-hmm.
Okay. So after they think about that inhalation part, then I tell them, okay, slowly breathe out through your mouth. And then imagine that you're slowly letting that air out of the balloon. Okay. And then additional cueing would be, okay, try to keep that balloon small and then slowly increase the diameter of the balloon, those things. So then you can kind of try to let the patient feel, the rib cage moving,
Mm-hmm.
their navel moving. And again, even if it's not correct that they're
Mm-hmm.
doing it, you just have to find the right imagery.
Mm-hmm.
Okay. Oftentimes the balloon works.
Right.
Okay. And other things that you can do is, of course, tactile cueing. So I
Mm-hmm.
would tell them, so it's, the balloon is right here.
Right.
Okay. It's not up here. And then sometimes I'll tell them to put their hands right here. Okay. If they're having a hard time with this, I tell them to put them on the sides.
Mm, okay.
So then I say, okay, breathe in through your hands. That's it. Because if you're breathing through your hands and your hands are on your waist, then you're doing the belly.
They're gonna feel it, right? Yeah.
They're gonna feel it. So if they have that feedback for themselves, it's exciting for them. And in that 20 minutes, you've actually taken their thought away from cancer for that 20 minutes. Because they're constantly thinking about their cancer, constantly. They're asleep, they're thinking about it, they're dreaming about it. But in that 20 minutes, they didn't think anything but the balloon. So it's much more than just, breathing intervention. It's just much more than that. You just have to kind of see how, and it's not just for cancer patients, really. A lot of orthopedic patients can benefit from it because oftentimes our orthopedic injuries are stress related, work related. So, I feel like that across the board, you can really.
Right, because there's a lot of like guests here have already mentioned like the deep breathing exercises are like basis in their treatment as well. I had Viel Oligario. She said that also deep breathing is one of the foundations in her yoga therapy sessions, and they're like, okay, so uh, it's really something like a foundation essential for every patient that they can benefit there. And one of my guests also said that the diaphragm is, as you also mentioned, is part of the core. So it's the roof of the whole core. If you're gonna think that it's the trunk is a cylinder, you have the pelvic floor as the floor, and the diaphragm is the roof of the core muscle. So that's a thank you for sharing that with us. So, aside from providing them with cueing with deep breathing exercises, what are the usual interventions that you incorporate or employ with patients that you see with cancer or cancer related symptoms?
So if I'm mainly seeing them for lymphedema, then that's that's a specialization. That's not necessarily just cancer rehabilitation. Right? So if we're going to talk about lymphedema, so the golden standard is called complete decongestive therapy, where you have 4 components. You teach them about skincare and monitoring. You talk about decongestive exercises. And most of the therapeutic exercises involved here is mostly range of motion exercises. Okay. And then the third one would be manual lymphatic drainage, which is I guess, they don't want us using the term massage for manual lymphatic drainage, but just to be simple about it, it's the mobilization of the skin. That is a little bit complex because you have to be aware of where the nodes are so that you'll know where to direct the fluid to. So that one is a little bit complex. And then the fourth one would be compression. So compression can be multi-layer bandaging or the use of compression garments. And then there's others, like compression wraps where they use Velcro, especially for lower extremity. Most patients won't be able to bend down to do it. So the Velcro wraps would work best. So for lymphedema, those are the main components that you have to go over with the patient. And your frequency can range from twice a week to 5 times a week, depending on what phase you're in and depending on what you're trying to achieve. The 5 times a week, just a brief note on that. You do that when you want to intensively decongest a limb to try to fit them into a garment, or I should rephrase that. You want to decongest the limb so that after the 2 to 3 weeks of doing the daily treatments, they get fitted for their compression garment. That way, it's the right size for them. Oftentimes, when they come to the clinic, they'll have measurements already for the sleeve or the stocking, but we have to repeat that after I've made the limb smaller. So, that can also be important to know that you have to coordinate with the whole clinical team. So you have to talk to the orthotist also. If we're talking about cancer rehabilitation, the most common things that you would treat is cancer-related fatigue. That's the
Mm-hmm.
number one. Number two would be chemotherapy-induced neuropathy.
Right.
So teaching them desensitization techniques. There's also gloves and socks that you can have them use so that they can sleep better.
Mm-hmm.
A lot of education there. And then you have to assess for falls, because if they have neuropathy in the feet, then you probably will have balance issues also. So then that, that opens up a whole new different kind of intervention. After that, I would say those are the main things. And then lymphedema, of course.
Mm-hmm.
And then everything else, you'll have radiation fibrosis, which is tightness and scarring of the skin because of radiation. So that involves more manual therapy.
Mm-hmm.
You have to work closely with the radiation oncologist there to make sure that you can manipulate the skin.
Right.
It can't, because they have to be, usually they should be done already with radiation before you try to loosen it up.
Mm-hmm.
So a lot of skin long-term side effects you have to know how to treat.
Mm-hmm.
And then the rest, I think, is pretty much about the same thing as we do for other patients.
Mm-hmm.
Range of motion, activity modifications, sleep hygiene,
Even
nutrition
sleep.
sometimes,
Mm-hmm.
nutrition. Mm-hmm.
Okay. So, do you also handle pain coming from cancer
Yes,
type
thank
pain?
you.
Mm-hmm.
Yes,
So,
pain.
so,
Pain is actually a big goal for
mm-hmm.
cancer patients.
So how do you handle that in terms of this is going to be a chronic pain and patients are, I don't know, they may not be able to like completely overcome it. How do you handle that in terms of physical therapy and education with the patient?
So pain management, if they have, significant amount of pain, they're usually on pain medication.
Mm-hmm.
If they are, our role as physical therapists is to make sure that they're compliant with the frequency of the
Mm-hmm.
pain medication. So it's almost kind of like being a nurse in this sense, where you ask them, are you taking it at the right time?
Mm-hmm.
Are you taking the right dose?
Mm-hmm.
So giving them tools, maybe like a calendar, and asking the physician if the patient, or asking the patient to talk to the physician if they can increase his or her dose. You can also recommend over the counter, not over the counter, but topical.
Mm-hmm.
That might be helpful for them. Of course, still asking the physician if it's okay. Besides pain medication management, it's also depending on where the pain is coming from. Because if it's a pain that's coming from a particular part of the skin,
Mm-hmm.
then they might be having scar tissue there.
All right.
So you can definitely help with that. And that, I've used cupping in the past to really loosen up the skin. That's really where your manual therapy skills would take place.
Mm-hmm.
If especially with radiation, and sometimes they'll have radiation if it's gynecological, then they'll have radiation in the abdominal area. So depending on the body type of the patient, there's lots of areas that fibrosis can happen. So we definitely can help if the pain's coming from there. Other kinds of pain is usually activity related. So then same thing, proper body mechanics, using different muscles if you can,
Mm-hmm.
adaptive equipment if they need it, and not just our basic gait training equipment. You can look into have the patient wear braces, splints, talking closely with the occupational therapist and asking them, what else can I offer for this patient?
Mm-hmm. Right. And we talked about earlier that the spectrum of patients that you're seeing from patients who were recently diagnosed to patients who were after surgery. So I've read somewhere before that they're advising now that it's best to, like, right after diagnosis, to see a physical therapist just to set a baseline for all the functions and all the mobility capacity of the patient, so that the patient has something that they can look back, right? So do you also like do that for those patients that are recently diagnosed, and creating a program for that patient?
So that is a big goal for every cancer rehabilitation therapist is
Mm-hmm.
prehab. So it's
Mm-hmm.
prehab. Unfortunately, I would get them from time to time
Mm-hmm.
if they're coming for a different diagnosis. Let's say I'll have an orthopedic based diagnosis, and then she or he was recently diagnosed with cancer. So then, I can treat that.
Mm-hmm.
In terms of physicians referring right after diagnosis, that doesn't happen often. And
Mm-hmm.
that's one of the biggest things that lymphedema therapists and cancer rehabilitation therapists is trying to advocate for,
Mm-hmm.
is to get that referral earlier. Or what I'm actually in the middle of implementing in our clinic is a monthly education class. So it's almost kind of like a diabetic education class,
Mm-hmm.
where as soon as they get diagnosed with diabetes, they are put in this class with a nurse,
Mm-hmm.
and they are given basic information about how to manage diabetes.
Mm-hmm.
So that's kind of like how I'm hoping the educational class is going to pan out. Um,
More
some
interdisciplinary.
interdisciplinary,
Mm-hmm.
yeah. Yeah, so the class, I'm hoping that even just a basic, few minutes with them, and them seeing that there is a therapist
Mm-hmm.
that's available if they need it in the future. And I think that's a big help already.
Mm-hmm. So for those, what types of program do you create or develop for patients who are recently diagnosed, aside from the of course, primarily the education? What, in terms of physical therapy program or development, are you like trying to create for them?
It's more on education about fatigue,
Mm-hmm.
what to expect, when to expect it, what to do when they have it.
I see.
And not too many, you want to be simple with the things that you tell them, because you don't want to discourage them to receive their cancer treatments either.
Right.
So I wouldn't explain, well, I will talk to them about lymphedema, but I would not, it can be scary for patients
Mm-hmm.
to know that this can be a chronic condition for them. And that can deter them to receive radiation, which is, of course, you don't want to do. You don't
Right.
want to discourage them from receiving treatments for cancer. So the program has to emphasize on coping strategies
Mm-hmm.
rather than alternative strategies. So we're not an alternative treatment for
Mm-hmm.
them.
Mm-hmm.
We're just here to advocate for them, supplement
Mm-hmm.
the treatments that they're getting from their oncology team
Mm-hmm.
and their primary care physician.
Mm-hmm.
And also it helps us in the sense that if we get them early, it's easier for us when they come back,
Mm-hmm.
because then you have an idea of what they went through.
Right. Right. Mm-hmm. It's important to see them at their baseline, so that you can know what they were before everything uh, happened. And it's also nice, I guess, for if they know that you're available, the physical therapist is available to help them in those times that they need it. That at least they know that there's physical therapy, or therapies are there to help him, and it's available.
Yes, because actually it's not very, even lymphedema, it's not very popular,
Mm-hmm.
the treatment. And not only in for patients, but even in the clinical team, with physicians, sometimes you have to spend educating physicians and
Mm-hmm.
letting them know when is it a good time to refer this patient, and not wait until it's so severe that it's going to be more complicated to treat.
Right.
So you're not just advocating for the patient, you're also advocating for the profession, and really having that communication with the physician, because, you know, of course, that's always a struggle for us sometimes.
Right.
But you know, it's an opportunity to bridge that gap.
Yeah. Some physicians are not like familiar in what we can bring to the team.
Yes, what we can offer the patient. Yeah, because, you know, these interventions are fairly new, and cancer rehabilitation is ever, you know, evolving. Lymphedema treatment as well, and there's, you know, always new things that we like in research. So it's I think it's we have a role to play in making it more accessible for everybody, for therapists, for patients, their families. Don't forget their families, because that's a big ally for you, and of course the medical team.
Right. And I think they only know that they're going to refer the patient with cancer to physical therapists when they start to feel those symptoms, and they're not aware that we can even see them
Right.
before the symptoms come out.
Exactly.
Right.
And sometimes they won't, you know, the patients are not aware that it's a symptom.
Okay. Oh, all right.
So, you know, catching these patients very early and just having that conversational interview is very helpful. And in the long run, it does make the treatment easier.
Right. And they might think that it's normal. It's a normal part of the
Right. And they're
cancer
just
intervention.
gonna, you know, live with it, and their quality of life can decrease. Yeah.
Okay. Well, that's great. Yeah, thank you for sharing that. So, you've been in the oncologic rehabilitation space for quite some time now. And what are the things that you've picked up or learned from seeing patients with cancer and cancer-related symptoms?
In terms of interventions,
In
or
terms of intervention in the whole perspective of your practice,
okay.
or what are the things that you picked up or learned from that experience?
The main thing I learned is I'm learning still every single day.
Right.
You know, these patients are going to teach you a lot. They're pretty much your teachers, these patients. The first time out of lymphedema certification, I had a patient. She's 67 years old, has been on a power wheelchair forever, since she was 8 years old.
Oh.
And because of an accident. So she had elephantiasis in the right lower extremity, and then she had history of cancer. So it was a very, you know, complicated case. And you know, at one point I was confused about what was I gonna do, how was I gonna help this patient. You know, there were so many issues. But, you know, making sure that you know, you have, or telling yourself that you can help this patient is very helpful, because it can get overwhelming. So I think the point I'm getting at is, if you get a challenging case, and oftentimes with cancer patients, you know, their history is challenging, don't get overwhelmed, and try to see the bigger picture and keep it patient and functional based. If you stick with that, you can't get it wrong.
Okay.
I think that's the biggest takeaway for me for seeing patients. Because even if they have like 20 symptoms, what is the most problematic activity for them? Start there. Even if it's just one, and you spend 3 to 4 weeks just on that one. You know, and sometimes you only see them once a week, depending on transportation. The family can't bring them. They don't have family. You know, it can be very challenging, but every little bit of information you give to these patients is a big help for them, and they're very, very grateful. These patients are very, very grateful most often.
So learn to prioritize what's what's
Mhm.
the most valuable or meaningful thing that they want to address on.
Exactly.
Mhm.
Ask the
Yeah.
patient what they want to work on.
Yeah.
And the other thing about treating cancer patients is trying not to be judgmental
Mhm.
also, because sometimes you'll have patients who have substance abuse,
Mhm.
who are still smoking even though they've had radical neck dissection for throat cancer.
Mhm.
You'll have those patients, and you're not there to judge them. We're not there to tell them, they're making bad choices. uh, it's really trying to uh, help them in functional activities and keeping the personal perspective, in check.
I remember one of my clinical managers back then mentioned that, well, they're adults; they're allowed to do certain
Whatever
things,
they want.
whatever they want. So
Right, right.
stick to what you can help them do, and let their bad decisions by themselves. All right, that's it.
It's
So,
hard though. It's hard because,
mhm.
especially you want to help them.
Right, right, right.
So sometimes I have to remember I have to take a step back and say,
Mhm.
this patient is not my daughter. This patient is not
Mhm.
my mother.
Uh-huh.
You want to help them, but if you're going to, I guess, be aggressive about your
Mhm.
treatment, then
Mhm.
you won't be able to do that. And
Yeah,
sometimes you have to let go and just let them decide for themselves.
right.
You're
Yeah,
just giving them information.
right. And that would be you're risking alienating your patient from
Exactly.
you and your treatment that they might benefit. So, right, if you've laid out all the information, it's up to them to decide,
If they're gonna
and
take
if they're gonna take it right.
right.
So for physical therapists, their colleagues who want to get into uh, cancer rehabilitation and or already treating patients with cancer related symptoms, what good advice can you give them in terms of uh, physical therapy practice and patient care?
My advice would be to take care of yourself.
Mm-hmm.
It's very important to, like I said earlier, to separate yourself from them,
Mm-hmm.
because again, these patients are very fragile,
Mm-hmm.
and they seek comfort,
Mm-hmm.
and it's easy for us to get attached to that.
That's true.
But it's important to not build that wall, but create that space.
Mm-hmm.
And when you leave that room, don't care try not to carry that outside of the room. Leave it in the room, because if you're seeing another patient, you have to start fresh.
Mm-hmm.
So I think that's my biggest advice, is because in terms of knowledge, you have it. It's there. Resources are there. It's If you spend time and you want to learn that's the easy part, I feel like. But the treatment that's hard is knowing when, like deciding when you need to let go and start discharging this patient, because you can't see all of them forever. You cannot.
That's true.
They can come back, and
Mm-hmm.
most of them do, but really having that clinical skill to decide when it's time for them to be on their own,
Mm-hmm.
is important. And you won't be able to do that if you're emotionally attached to each
Mm-hmm.
patient. So that's my biggest advice, is the meditation and the mindfulness and the diaphragmatic breathing that you teach to your patients, do it for yourself.
Right.
And not just for cancer rehabilitation therapists, it's also for all physical therapists.
Mm-hmm.
I think it's important that we don't get burnt out. You won't be able to help your patient if you're not taking care of yourself.
Right. It's easier said than done because in our line of work is we are encouraged or we do best in our work if we are emphatic and being putting ourselves in our patient's shoes. And sometimes it's overwhelming once
It
your
is.
patient cries at you.
Right.
and tells you their problems. Sometimes they're unsure of the future, learning that their cancer has come back and things like that. So it can be overwhelming. And you're right, self-care is
Self-care.
still a priority for us physical therapists in order to help more.
Yes, yes, because you have to keep yourself very elastic so
Hmm.
you can do it for more people. And
Right.
my instructor before said, when you enter a room and you're treating a patient, try to remember that it's their time.
Hmm.
It's not your time.
Right.
It's their time. So if they talk about their mother or they talk about their daughter, it's
Hmm.
their family, not yours.
Right.
So I thought that was very helpful because
Hmm.
then I can create that space between me and the patient.
That's true. Just listen, let them speak. They might
Mhm.
just need someone to listen to
Exactly.
let it out. They're not
Hmm.
really seeking your advice or
Advice.
info.
Exactly.
They just want
Mhm.
someone to listen to. So that helps them out.
Yes.
Right. All right. So thank you for spending your time with us and sharing your experiences with your practice in cancer rehabilitation. I just have before I let you go, I just have my three last bites my three last questions. Um, my first one is in order to elevate our profession, so what should physical therapists do?
I would say communicating more with the other clinical team members.
Hmm.
I think it's important that we don't alienate ourselves from nursing, from physicians, uh, from the support staff.
Hmm.
If you work in a outpatient clinic, your support staff is important. If you don't have them, you can't you won't be able to do your work.
Right.
You can't focus on the clinical side of things because
Hmm.
as you know, in when you work, it's not just the clinical, it's not just the patient, it's there's other things that you have to do.
Hmm.
I really think being a team member um, for the patient, and for you, and also being part of the education for the patient's family.
Hmm.
I think that's important. Don't forget to include, if they do have family members, to communicate with them, with the patient's consent, of course.
Hmm.
I think that's the biggest advice I can give.
All right. Second one is what's included in your physical therapy toolbox whenever you go to work? What's your go-to tools that you use?
My hands.
Your hands, quite manual. Mhm.
Yeah, my hands. With lymphedema therapy and cancer rehabilitation, um, my hands are the biggest asset
Mhm.
because sometimes, even if you're not really performing a full sequence,
Mhm.
just having that cueing,
Mhm.
okay, and that connection with the patient, um, it helps them a lot. Sometimes it's even more helpful than verbally cueing them.
Mhm.
Sometimes they'll be talking about their day, and I'll start already, cueing their shoulders, relaxing them down. They're speaking,
Mhm.
they're venting their stories out, and I'll be like, oh, okay, breathe, breathe, okay, and then what happened? So in the
Mhm.
middle of that, you're multitasking. So it's
Mhm.
it's really my hands. My
Right.
hands are my biggest asset.
And my last question is the show is called PT Meal. It's a complete meal, as I've mentioned in my intro, of inspiration and information. For my last question is what are the three ingredients that are essential for you that you carry with you every day? It may be a motto, a principle, a belief, a value that you carry with you every day that you think are essential. In short, what are the three things that make up June Nocete?
Oh gosh, a hard question. You should have texted me this question. Okay. I would have to say open ears, I guess,
Hmm.
That's the biggest thing, and not just for patients, but for your coworkers. You can close them later on for your coworkers. I'm just kidding. Open ears, mindfulness
Mm-hmm.
of what I say.
Mm-hmm.
I think that's very important because you are a representation of the clinic and of the profession.
Mm-hmm.
Mindfulness of your actions.
Mm-hmm.
And then the third one would be to try to try to have fun with it, with
Mm-hmm.
your work.
Right.
As I said earlier, you can be creative, and you can be the fun part of their day. So when they come in, they're usually like in severe pain. You
Mm-hmm.
can turn that around. You have that power
Mm-hmm.
to turn it around. And sometimes you don't, we're not talking about slapstick,
Slapping jokes.
no,
Charlie Chaplin.
right, right. But listening to them and making, witty side comments, and maybe making a fool of yourself a little bit, and just
Mm-hmm.
just trying to kind of let them loosen up.
Mm-hmm.
Of course, you can't do that immediately on the first visit. You want to
Mm-hmm.
be professional, but you can be professional and fun at the same time.
Right.
And it really does help also for you, so that you can kind of relax a
Mm-hmm.
little bit. And it is all serious. It's important to have a break.
Right.
Mhm.
So open ears, mindfulness, and having fun.
Having
All
fun.
right. All
Yes.
right. So again, thank you very much, June, for spending time and sharing again your experience and your work with us as a physical therapist in cancer rehabilitation. And as a takeaway, your pabaon natin for the listeners, what do you want them to take away from? If there's one thing that you want them to take away from this episode, what would that be?
Don't forget about yourself.
Mm-hmm.
Yes, because I really, I really wish I knew before how tiring it can be to be a
Mm-hmm.
PT. You want to just, keep going, and then you get to a point where you're stuck. You're
Mm-hmm.
just stuck, and you
Mm-hmm.
don't know where to go. So I really think it's important to have dreams and goals, but not to compromise your quality of life either. The same advice that we give to patients. That's my biggest advice, I guess. I hope I hope somebody will find that helpful, because I know that would have been helpful for me
Mm-hmm.
in the beginning.
All right. Again, thank you very much for your time and being in the show. It's my pleasure to have you here.
Thank you.